Welcome to Eclipse of Wellbeing podcast, where well-being, culture, and technology meet real life. I'm your host, Chiamaka, and this is a space for honest conversations about health, identity, ambition, and what it really means to be well in our world today. Let's jump in. So today I'll be speaking to Dr. Amaka Azie. For listeners, Amaka, could you please introduce yourself?
I'm Dr. Amaka Azie. I am a GP working on the Wirral, and I graduated from University of Benin City in Nigeria and got my MBBS there, and also graduated and then did a training on the Wirral to be a GP. Got my MRC GP on the Wirral. Been practicing for up to over 10 years as a GP. And and I'm also a part-time writer as well.
Yeah, awesome. Thank you so much. So what's your journey into medicine? Why did you choose this path?
Uh, I won't say it was a conscious effort, to be honest. I was just good in sciences and it was just a natural flow of things. But as I continued to go into medicine, I began to enjoy it, and I'm glad I eventually found myself being glad that I followed that path because it's especially general practice, which is quite holistic, rather than focused on one part of the body. We're seeing the person as a human. Um, so we're seeing not just the illness, but the person behind the illness, which is quite quite fascinating.
Awesome. You said you're also a writer. You're a romance writer, right? How did writing become part of your life? How does it fit alongside being a doctor?
That was my passion. So I've always wanted to go into writing. So if there was any conscious choice, I wanted to. But back then, I think my parents thought, you know what, the life of a writer is quite uncertain. But if you're good in sciences, the life of a doctor will be rather certain. And therefore, I went into the choice of being a medical doctor. But I've always written. I was in the press club in secondary school. So I was in charge of writing the news articles that was read in the assembly every day. So I used to pick up interesting things from the news and edit it and make a press release every week. So I was the president of the press club. I also wrote little handwritten notes that I shared with my classmates. And so writing has always been a part of me, but I first self-published in 2016 after I had finished my medical training. And I was like, okay, I've done the medicine bit. Now let me follow what I really enjoy doing. And that's how it started.
Oh, that's such a warm story, Amaka. I think I've always loved the idea of writing as well. Like you, I wrote in secondary school, shared with friends. Definitely a passion I'm trying to follow, but it's really inspirational. You've kind of got ahead and self-published, which is something I'm thinking about as well. So that's really nice to hear.
That's
Thanks for
good.
thanks for sharing that. So today we will be focusing on women's health, and I'd like to dive into those questions because I would really like to hear your opinion about a lot of things. So, in your GP work, what are the most common women's health issues that you see?
So very vast and very under researched. Many of the women health problems. Number one is period problems. That is a very big common problem, both from the young who are just starting the periods to those who are ending periods who are menopausal. So we start from people who have delayed periods to those who have heavy periods to those who have irregular periods to those who have very painful periods. And there is there is really so much more to be done in terms of how to make this monthly necessity um, for reproduction more bearable so that women don't have to suffer through it. So there's still much research need to be done. I also
Mm.
come across contraception issues, which is another poorly researched because I feel that it should be more male-centered because more men can get more women pregnant than women can carry pregnancy. So, but women bear the brunt of contraception, which is still very, very, I think, primitive. So yes, I deal with contraception issues, with advice about side effects, about starting them, about removing them. Also, I deal with fertility issues, which unfortunately, again, even though it's supposed to be a shared journey between men and women bear more of the brunt of fertility issues. So I see women, who trying to get pregnant. Um, I also deal with women who don't want to carry on with a pregnancy, and that's another women health that I deal with. I also deal with perimenopause, sexual health, when it comes to also not only contraception, but sexually transmitted infections. So women health also now other sorts of pathological problems, breast cancer, ovarian cancer, uterine cancer, and that are specific to women only. Although men can have breast cancer, but it's more common in women. So there's a vast number of things I come across when it comes to women's health, and I wish it was more. There were more options, more research into how to make these treatment options easier and vaster for women to choose from.
Mm. So, for someone who doesn't understand primary care well, could you just enlighten me a little bit on what's the GP role in women's health? So, what you manage directly versus what you refer? Because, I'm sure a lot of people out there are wondering this.
So I'm going to talk about the UK where I've practiced since I finished my training in primary care. It's different all over the world. But in the UK, primary care is the center of patient care. So it's the first point of call. It should be the first point of call, although it's not usually that way because some people still end up in secondary care without going through primary care. But it should be the first point of call where if there is any concern about your health. So, for example, a mother concerned her 14-year-old or 15-year-old has not started seeing her period. Instead of going to A&E, which is for emergencies, or you can't just show up at the gynecologist's office, you go through your GP. Now, the GP then, which is me, I listen to the history, I take a examine if there is examination needs to be done. I then discuss my findings, and if there is investigations that need to be done to make a proper diagnosis, the primary care can handle this. That means a GP can handle it. And if there is a treatment option which we can easily prescribe or manage, for example, if we can reassure, oh, she's just 15, give it another year, or she's developed all her secondary sexual characteristics, so she's definitely on her way to having a period. Then we manage it in primary care, or if it's a heavy period and we say, oh, we can give you some medication that can help you with reducing the period heaviness or reducing the pain, we prescribe it. So this is where the GP's role is to manage things that are simpler, that are not specialized. Now, for example, if we've done the best we can and this patient is maybe 1 year, 16 years old, she's developed everything, so there's no reason why her period should not have started. We've done the ultrasound and all the investigations we need to do, and everything is in place. Then we refer to secondary care for further investigations, or we refer to the gynecologist, who is usually the secondary care person. Or, for example, if we have investigated and found something that is not in our capacity to manage. For example, we find a tumor that has caused this person not to have a period, like a pituitary tumor, or we find a massive maybe, or we find something that's not supposed to be there, maybe in the ultrasound. Maybe the person does not have a womb. These are some things that we have to refer to secondary care because we don't have the training or the expertise to manage such specialized conditions. So in the GP is the first point of call in any women health issue. If a woman notices a breast lump that feels odd, or she's not quite sure if she can feel it, she comes to the GP. She can't show up in A&E because it's not an emergency. She can't just show up with the gynecologist because the gynecologist would like to know what your GP thinks first before seeing you. So she has to go through to the GP, who will then take a proper history, examine, and if the breast lump is concerning, the GP can refer to the secondary care. If it's not that concerning, GP can say, maybe we'll watch and wait, see how it gets on. If it's not any better, we can refer. So we are the first point of call to all people, all women who are who are experiencing any health concerns.
Wow. So you mentioned some conditions there that I probably never even thought of, like, the possibility of checking and somebody doesn't have a womb, for instance. Yeah, so you see quite a huge range of different things. So narrowing the focus a little bit, and maybe looking more at what's overlooked. In your view, which areas of women's health are least listened to or least prioritized? Because you mentioned a few there, like menopause and infertility, etc.
I
And
would
why?
I would say number one is menopause, and I think so. I feel that it's one of those conditions people expect women to get on with it. It does not affect men, and I'm sorry, we're unfortunately in a very patriarchal world where much of decisions and rules were created by men, because there was a long time where women were not allowed to even go to medical school, or go to work, or vote, or make decisions, or research. So many of the decisions about health were put in place to protect men who made those decisions. So menopause does not in any way affect men, and therefore the research to menopause is not great until women started taking it upon themselves. So HRT, for example, is relatively new. There's still a lot to be done, too many side effects, too many risk factors, too many concerns. So menopause is one of them, perimenopause, menopause, because it greatly affects the mental health of women. It affects women in many ways, in sexual function, and other things. So that, I would say, is number one for me. Number two, I would say, is periods as well. Because again, it does not in any way direct the structure which medicine has been built around, which is solely a woman problem. So there's lots of things to be done. There's not enough research to how to manage this condition that most women will go through every month. It's if they're having painful, debilitating pain that can prevent them from doing anything for 3 or 4 days, sometimes a week, every month. That's 1 week of lack of productivity in a woman who can otherwise be productive. So there should be more research about how to stop it, how to prevent it, how to control it. So that, I think, is under research. And then I would say number three, even though this affects more men or women, I wouldn't say it's not research, it's is left to be a woman problem is contraception. I feel a man who can get, if a man sleeps with 100 women in a day, he can get all of those 100 women pregnant. He can get more than half of them pregnant. If a woman sleeps with 100 men, she can only get pregnant once. Okay? So one man in a day can get 100 women pregnant. One woman, even if she sleeps with 100 men a day, she can only get pregnant for one man. And she may not even get pregnant. So at the end of the day, that's based on her cycle. I think if it was not for patriarchal control of the world, contraception should have been focused on men and not on women. Because these women have to deal with hormones from cycles, then to deal with hormones from pregnant contraception. A majority of contraception is hormonal based. There's only one which does not involve hormones, one that is completely hormone free, which is the copper coil. Every other thing involves putting women through a very stressful hormonal injection, just ingesting hormones in themselves in form of injections, in form of tablets, in form of coils. And even the one that is copper coil, which is non-hormonal, is still very invasive. Okay, if we're talking about other invasive contraception, we're talking about using sterilization, where a clip is to clip the tubes. That's very invasive, sometimes has to be done under general anesthesia. So women who can only get pregnant in once every month in a cycle have to bear the brunt of preventing pregnancy, whereas men who can get 10 women pregnant every time a man has sex, there's the potential of getting a woman pregnant, does not have to do anything but wear a condom. And there are women who are allergic to condoms. Okay, so there are women who are allergic to condoms. So if the focus of contraception, if it was not a patriarchal world, should have been on men taking hormones to stop themselves from getting a woman pregnant, because there are more men that can get a woman pregnant than a woman can get pregnant by men. And so it goes to show that it was very patriarchally controlled contraception, and to put that
All the burden on the woman.
burden on the
Yeah.
women,
Yeah.
when the risk is more on the men,
On the
from the
men.
men. Yes.
Absolutely, absolutely. So NHS specific, let's look NHS at some of the NHS specific questions that I've got here. So specifically about NHS, what do you think the biggest barriers are that women are facing right now? So, whether it's appointment wait times, referrals, stigma, time pressures, or anything else.
It's always about time pressures, number one, and how seriously women's problems are taken. So, first of all, many women will say, I'd rather see a woman. And I understand that. I understand that, because telling a man you're having painful periods, unless you've experienced it,
That's right.
or you know somebody who's experienced, you'll be dismissed.
Yes.
Get on with life. So there is that pressure for women to see only women doctors. And what if there are no women doctors available in that practice on that day? They tend to wait until there's a woman. And it all goes, so those are the constraints. For example, a breast lump, you might want only a woman to examine you, and on that day, there's only 3 men working, and therefore you lose that opportunity to have that physical examination. Now, do men go through that? Absolutely. But there's less of, I see, reluctance from men to be examined by a female doctor if there is an intimate exam being done. In fact, I find the opposite, that they don't want to be examined by a man, which is quite odd to me, that women want to be examined by only women and men want to be examined by only women, which is quite fascinating thing. I've come to understand that a man with a penile problem will not want another man to examine his penile problem. And I'm like, oh, so women get to do even the double work, But time constraint, demand for a specific gender to be taken seriously, and again embarrassment and stigma.
Mm,
So two people have sexual activity, a woman's sexual infection, for example, if it's genital herpes, it's embarrassing for the woman. She's afraid to be looked down upon or judged, so she keeps it to herself. Suffers in silence. For example, contraception, abortion. A woman is afraid to say, I want to start contraception because that will mean that she's exposing to everyone that she's sexually active. So there's still that mind limitation when it comes to contraception, women asking for contraception. Again, that's why I'm quite not happy that it's on women who have to go to ask for it when the contraception is for a sexual activity that involves both men and
mm.
women. So especially knowing that women are judged harsher for requesting that contraception in the first place. Other things I find that can be limiting mentally for women is infertility. For some reason, it's like a burden on the woman, whereas it may be a couple thing. I've found that in some cases, it's not that the woman is unable to have a baby, it's that she's actually allergic to the male, her partner's sperm. But in that case, it's her that bears the burden of all the
Mhm.
contraception, all the childbearing. She's the one who has to get her eggs scraped off. She's the one
All
who
the intrusive
all
procedures.
the intrusive procedures have to be, the woman has to bear the burden. So there's a lot of limitations that will make a woman not want to seek health care. Some of them are doctor based and organization based, but some of them are also based on societal behaviors and patterns where women are judged for
Mm.
having a healthy sexual appetite. Women are judged for the consequences of sex in case there's a pregnancy that she doesn't want to carry on. So there's a lot of limitations women face when it comes to seeking healthcare.
Mm, mm. So are there groups of women who you think are more likely to be missed or dismissed in the system? So for example, whether it's by age, culture, language, or socioeconomic status even.
Oh yes, absolutely. Almost all women of it spans from all it spans through from all most, let me say, age. So the older you are as a woman, you're dismissed for your medical conditions. Young, the younger you are as a woman, you're judged for your choices. Socioeconomical class, why are you getting pregnant? Why do you have 10 children? What is her access to contraception? You don't think about it. Does she have contraception readily available? How is her access to get those checked, instead of judging her for having too many children? She didn't have those children on her own. Somebody made her pregnant. Yes, so age is a factor. You've mentioned it all. Socioeconomic class, another big factor. And even culture and religion is another big factor. So culturally, for example, a woman who is told contraception is a sin, for example, may not want to have 15 children or 10 children, but because she's culturally been told that that's to seek a way to stop that is sinful, might be a limitation to healthcare for her.
Mm.
So
Yeah, yeah. Mm. Thanks so much. That's really, yeah, so interesting. I mean, for the next questions, we'll probably dive into more digital health. So, in this case, when I say digital or digital tools, for everyone listening, I mean things like online booking, triage, apps. So, any sort of wearable devices or any sort of systems. So Amaka, where do you already see digital tools showing up mostly like in women's healthcare today?
I find them helpful. I find them very helpful. Tracking your period now can be digital. So that's one. So that can help you organize things rather than calendars, which you can forget to input. Booking appointments to see your GP can be digital. You don't have to ring anymore. That is also very helpful to control the influx of people who ring at 8 a.m. You can do it on your own time on a computer, checking your results. You don't have to ring up anymore. You can log into your NHS app. You can check your results. Also, support groups. You don't have to meet up on one. So if there's a rare condition you have and you want to meet up with people with those rare conditions, there are now Zoom meetings which that can hold. And so support groups don't have to be face to face. You don't have to drive all the way to Manchester to meet a group of people with your rare condition. You can all
Mm.
meet up online. There are also, in terms of mental health, women mental health. There are those period apps also help you to talk about your mental health while going through your hormonal changes. So yeah, the digital age is here to stay. I know a lady who took a picture of a funny kind of color mole on her body and put it through ChatGPT. And ChatGPT said, go and see your doctor immediately. This looks like a melanoma. And it ended up being a melanoma.
Wow.
She was very stunned
Wow.
and it saved her life because they were able to excise it completely and it hadn't spread. So that was very, very shocking when we heard that. And so we encourage our patients now. You know what? There's no harm in using ChatGPT. If you have a funny looking rash, just don't trust it. Just use it, but always see your doctor as well. But there's no harm in using it to prompt your decision making in a way.
Yeah, don't trust it explicitly,
Don't
but
trust it
yeah.
explicitly, but there's no harm in doing that because that lady, if she hadn't done that, she might
Hmm.
have just not taken that
That's
mo-
right. She would
that
think it will fade
most,
away
yeah,
soon, you
more
know.
seriously. So digital age is here to stay. Any doctor who fights against it isn't realistic. However, replacing human contact is where we can never ever replace human contact. So I'll like give you examples. In the shops, when you go to the shops now and you do the self checkout, I find that it's going to in the long run might be very damaging to the elderly who's maybe the only time they get to interact outside is when they go to the shops.
That's
So
right.
they go to the counter and they see one of the and they have a little chat. I never begrudge the elderly those who chat with the cashiers because I know that that might be once a week the only time that they have to interact with people outside their family.
Wow.
So we cannot replace seeing your GP. We cannot replace physical examination. We cannot replace face-to-face contacts. But definitely, computers make life for everyone easier, and I will never begrudge that.
Okay. Yeah. So the last time we spoke, you gave a great example of, so I'm talking now from a social media as educator point of view, people kind of going on social media and educating themselves on all sorts of different things. And you had given a good example of discovering menstrual cups via TikTok. How often do you see social media shaping patients' choices?
Oh, definitely. Social media is very important in although it has its downside because there's lots of misinformation spreading around. It also has its outside where there sometimes you get good information. So I remember that menstrual cup incident. That was quite interesting because I got tired of using tampons and pads. The chemicals, the irritation, and I heard somebody who just put on a tweet that you just put on the cup, and she said this is the lifesaver nobody talks about. And I googled it and I used it, and I found myself, oh my God, this is so wonderful. Then I thought to myself, there are many people who can't even afford menstrual pads every month. You
Mm.
see, so this is another burden. This is something that women have to go through every month. I wonder why menstrual pads are not free. I wonder why menstrual pads are not free, but condoms are, but menstrual pads are not free. So this is another thing that shows how much little consideration is put into the women
That
health.
is such a good point.
Little consideration is put into women health. Anyway, so there are people who can't afford it because it's about $2.99 for 3.99, is it for the tampons, and about 1.99 for the cheapest pads would be 1.99,
That's
if not,
right.
yeah.
Yeah.
So you imagine if somebody is living very rough, they don't have a job. That is a lot of money to put in a menstrual pad. So, but if you get a menstrual cup, you buy it. You can use it over and over and over for 18 months, I think, before you need to change it. So that is cheap in the long run. So I think you discover a lot of things from social media. You certainly discover that you may not be the only one suffering a particular thing. I know a lot of women are now more open about painful periods on social media. So there's a lot of people who are no longer hiding menopausal. I remember the first time I had a hot flush, I put it on social media and I got people who reached out to me who said, you know what, I've been experiencing this. And it was quite interesting to see that it's just having somebody else acknowledge what you're going through is it can sometimes be therapeutic in itself.
Mm. Can you
So
describe what that would feel like a hot flush? Because I mean, you I would have thought you were young to have it, but some of the research that I'm going through shows that Black women may experience early perimenopause and menopause.
yeah, my first hot flush was when I was 44. And I woke up, I woke up very hot and my bed was wet. And I was like, oh, I felt it was very odd. And I felt like I was heated up from inside, burning up from inside.
Wow.
And it was in the winter. So you can imagine you're so hot, but it's cold outside. So it
Mm.
was just terrible because I had to strip off all my clothes. But at the same time, I was cold. So it was the horrible feeling. And I remember I didn't know what it was. So I thought, oh my God, I've developed cancer or something.
Oh my
So I
goodness.
went Googling, and I'm a GP, so I should know better. But I
Yeah.
went Googling and thinking night sweats, what causes it? And obviously, if you put night sweats on Google, cancer is number one, all sorts of illnesses are number one. And I went to the gym and I just said to an elderly lady that, I woke up on the bed and it was, and I'm going to see my GP. And she said, oh, how old are you? I said, I'm 44. She said, are you sure it's not menopause? And it just clicked. Just
Mhm.
that word clicked. And I said, oh my goodness, why didn't I think about it? And then I called my mother. I said, my mother said, you know what? Mine started at 40. It was very bad.
What? That is
And I was
crazy.
like, why didn't you say anything? Why didn't you say anything?
Because we don't share this information as women. Like,
Yes.
we don't.
There's so much stigma to it.
Yeah.
And then I went to my GP, of course, did all the tests, everything came back normal. And I realized, oh, I'm perimenopausal, this is it. So because I now found out what it was, I was less emotionally distressed by it and I'm better off coping. I went to buy pajamas for perimenopause. There's actually things in the market for people who are experiencing menopausal symptoms. If you don't want to go on
Really?
HRT, yeah,
I didn't know that.
there is a line of pajamas or nightgowns that are still for perimenopausal people, and there are bed sheets you can use And I got lots of tips from the members in my gym who gave me tips, which was quite nice. So there's good room for social media and interaction about women health, because it's very poorly researched, and there's a lot of stigma surrounding many conditions dealing with women health. And only women have to take away that stigma. The power to take away the stigma lies with women. That's why I'm now, when I saw a woman who walked into the store to get a condom, I was so proud of her. I did not feel embarrassed. I felt, here is a young lady who is taking control of her sexual health with no embarrassment. And that is very commendable.
That's awesome. What do you wish more people understood about perimenopause and menopause? Just still on that.
I wish more people understood that it's not just a woman problem. I wish more people understood that it's a family problem, because here is a woman whose hormones have been sort of yanked away from her. They're now going into a mixture of haywire thing. It affects her mental health, affects her physical health, affects her sexual health, affects even her interaction with her family. So it can cause irritability, where she starts to snap at people. So if everybody understands that, my mom, or my sister, or my cousin, or my co-worker is perimenopausal, there is more support given to that person rather than that bitch. Sorry if I can use that word, but
No, that is, yeah, that
that
you're
bitch. That's
hitting some really good points here.
that's what people will say. Oh,
Yeah.
that old, B word. Yeah.
And the individual themselves will be so hard on themselves. I mean, I think we've all experienced that mommy guilt. So it pretty much could increase during that time where
Yeah.
you feel guilty for acting in certain ways, and then you begrudge yourself for days. But
Exactly.
just a little bit more understanding on your part and the people around you could actually prevent you getting to that point of maybe lashing out and stuff.
Absolutely. I just keep telling my daughters, "Oh, I'm perimenopausal. It's just a mood swing. Don't worry." And I'm glad I'm telling them that, because I don't want the secrecy. Now, God bless my mom. She did the best she could, but the secrecy is it has to stop with our generation. We have to stop keeping secrets from our daughters about women's health. We have to be proud. We don't have to hide condoms from them. In fact, we should encourage them to be able to go to the store to get a condom. It's nothing to be embarrassed about. You're being safe when you're sexually healthy. We should encourage them to go and get contraception if they want to, not to be embarrassed if they're sexually active and they want contraception. We encourage them, if they're having heavy periods, to be able to say to their boss, "My periods are heavy, I'm feeling pain, I can't come to work." We encourage them to be bold about their health, because at the end of the day, hiding it is not helping anyone.
That is awesome, Amaka. This has been such a lovely conversation. If a listener could take one practical action this week to advocate for their health, you've just mentioned a number of examples for, the younger women. Is there anything else you'd like to add to that, maybe specifically for midlife women?
I'll say this to women, young and old: women's health is everybody's health. Just as men's health have been taking priority over the world. There are so many medications for erectile dysfunction, so many treatment options for prostate problems, so many. Women's health also matter, and therefore do not let anyone shame you to accepting that, oh, that's just what your body does. You should get used to it. If you want, if you want an epidural and you don't want a natural bed because you don't want pain, don't let anyone shame you to say, oh dear, why are you taking pain relief? Just be a woman and give birth like the Hebrew women. No, you don't have to associate
The
pain.
number of times I've heard that term,
You don't
honestly.
have to associate pain with childbirth. If you want to go straight out for a cesarean section, don't let anyone shame you into having a natural birth. If you want to have contraception, don't let anyone shame you into contraception. If you don't want to have contraception, let anyone shame you to having contraception. If you, whatever your health as a woman is the health of the nation. And therefore, you should be bold enough to make choices for yourself that have nothing to do with societal influence, but that they are choices that you want to make for yourself.
This has been such an enlightening session, Amaka. Thank you so much. Where can people find you, your work, your writing, or anything else you'd like to share?
I write romance, so it's basically mushy, mushy love stories set in Africa. People can find me on Amazon, on iTunes, on Kobo, on Barnes and Noble, on wherever ebooks are found. My paper copies are mostly on Amazon, not widely distributed. I've just signed a contract with a publisher called Paperworth. So I'm
Congratulations.
Thank you, thank you. More books that are traditionally published to be coming from me,
That is
particularly in
fantastic.
Nigeria and Africa. Yay, that's exciting for me. About my medical work, I'm still just a local GP. I do just a few part-time days in the walk-in center, and I'm sticking to that because I love it. I love the excitement of meeting new patients, and that human contact. So that's me and my career for now.
Fantastic, Dr. Amaka Azie, everyone. Thank you so much for gracing this occasion with your presence. It's been so insightful and enlightening. Thank you so much.
Yeah, thank you. Bye.